I would just want to talk about some case that describes some concepts we can review in pulmonary physiology. Obviously, I wish I could be there with you guys because now we have to go through all the troubles of Zoom, but maybe sometime in the future. I actually spent a month at Tikar and Besa Hospital many years ago when I was a medical student. So I can't say I remember much of my Amharic, so I'm sorry about that. So you'll have to bear with me in English for this. So our case is a 74-year-old male who presents to the operating theater emergently for an exploratory laparotomy due to concern for ischemic bowel. When he gets to the operating theater, he's wearing a non-rebreather mask at 100%, and he's in respiratory distress, breathing at a rate of 36 times a minute. You have a little bit of time to briefly review his history, and he has a past medical history of chronic obstructive pulmonary disease, hypertension, diabetes, obesity, and gastro reflux disease. His medications that he takes at home include aspirin, 81 milligrams, lisinopril, atorvastatin, metformin, omeprazole, metoprolol, fluticasone, salmeterol for his COPD, as well as tiotropium. His vital signs before you induce anesthesia are as follows. Blood pressure is 109/69, heart rate is 75, respiratory rate is 36. That oxygen saturation is 92 on that 100% non-rebreather. Additionally, he is 140 kilos and is 173 centimeters tall. So when you examine him before induction, he is alert and oriented, but he's speaking in very short sentences and appears in respiratory distress. His cardiac exam is relatively unremarkable. His pulmonary exam is notable for diminished breath sounds at both bases with fine bibasilar crackles and scattered wheezes. And then his abdomen, consistent with his concern for ischemic bowel, is distended and tender, and he has guarding. So the patient is induced for anesthesia with midazolam, propofol, fentanyl, and rocuronium, and he's easily intubated via rapid sequence induction with a MAC4 blade and 8.0 endotracheal tube. His oxygen saturations during induction fall to 60% briefly during the time that he's intubated, but as he's connected to the anesthesia machine on tidal volumes, 450 of volume control, respiratory rate of 16, and a PEEP of 5. You keep him at 100%, but his oxygen saturations, even after you've confirmed appropriate endotracheal tube placement, still do not go above 85. So what are some causes of hypoxemia that could explain this patient's persistent low oxygen saturations? Some of the, you have to think about all the usual differentials for hypoxemia. So one of them is because you have low mixed venous oxygen, and that can be because you have either low cardiac output that's not able to provide oxygenated blood to the tissues, or the patient has a very low hemoglobin. You can have low FiO2, but this patient we said was on 100%, so that is unlikely to be the cause. You can have ventilation perfusion mismatch, where there's areas that are where there's variability in how well gas exchange is occurring. Alveolar hypoventilation, so that is always on your differential for someone who is has a low oxygen saturation, but this patient is on mechanical ventilation. So while there may be areas of ventilation perfusion mismatch, it's not because you're not able to control the patient's breathing rate. And then you can also have a shunt on the far end of the ventilation perfusion mismatch, and that can be either at the level of the alveoli or anatomic proximal to the lung. And then diffusion limitations. So if any patient who has some kind of interstitial pulmonary fibrosis or Restrictive lung disease can have issues with gas crossing the membrane due to some diffusion abnormality. So based on all the differentials for hypoxemia here, what do we think is the most likely cause of hypoxemia immediately after induction of anesthesia? Well, I guess the low cardiac output is always a possibility, but this patient doesn't have a history of heart disease. But with the change in afterload and low systemic vascular resistance that comes after induction, that can certainly be the cause. We already discussed that you're controlling the not only the breathing rate with the mechanical ventilator, but also your FiO2. So it's unlikely to be low inspired oxygen or alveolar hypoventilation. Diffusion limitation usually is suggestive of someone who comes in with some prior history of lung disease that is usually restrictive in etiology, and this patient has obstructive lung disease, so that's unlikely the cause. So that narrows it down to either ventilation perfusion mismatch or shunt. So let's talk about those. So what happens when a patient is induced for general anesthesia? So one of the most important volumes in the lung, especially for the anesthetist, is the FRC. And do you guys know what the FRC stands for? Yeah, okay. So it's the functional residual capacity, right? So what happens is a number of things happen that affect the patient's functional reserve capacity as they go under anesthesia. Well, the first thing is they go supine. So when the patient goes supine, that changes the pressure on the diaphragm from the abdomen, which decreases your FRC. After that, we know after anesthesia is induced, the patient has a further drop in their FRC. If you paralyze them, that can also affect them. And then with surgical positioning and displacement from when they manipulate the bowel, all of that is going to affect your functional residual capacity. And then to review, well, what is our functional reserve capacity? Well, it's the volume of gas in the lung at the end of a normal expiration. So there's no airflow at that point, and your airway pressure equals ambient pressure. And this functional reserve capacity serves as a reservoir for oxygen that allows, that is also an element of the remnant alveoli being open at end expiration. The closing capacity is another volume or capacity that you need to know about. And this is the volume at which, the volume in the lungs at which alveoli collapse. And you can see here, this is a spirometry of a normal patient. And their functional reserve capacity is higher than their closing capacity. So what happens to the FRC under anesthesia? Well, we've seen already that it declines, and usually this decline is anywhere between 16 to 20%. And it happens right after induction, and it reaches its lowest point within the first few minutes and doesn't return to normal until after anesthesia is completed. And it's also reduced whether the patient is paralyzed or not. And it's primarily due to effects of the chest wall, abdominal muscles, and the loss of diaphragmatic tone that can happen with or without paralysis. And then how does positioning affect the functional residual capacity? Well, one of the first things you do when the patient undergoes anesthesia is you lay them supine. And you can see here in a standing patient, the functional residual capacity can be up to, it is the highest. And as you incrementally put the patient into supine position, they have a loss in their FRC. And the other thing you'll note is as you go from the supine position to the head down or Trendelenburg position, it declines even further, which is why when you have patients who are in this position for prolonged times during surgery, because the surgery requires it, you can have more difficulty with maintaining oxygen saturations. And then we talked about closing capacity. So again, this is the volume at which the lung alveoli collapse. And this can change. And as the patients get older, as they have other kinds of intrinsic lung disease or pulmonary problems such as pulmonary edema, the closing capacity can actually go above the FRC. And so why does this matter? Well, this results in collapse of alveoli at end expiration. And then some additional factors. So anything that's going to affect your abdominal, that's going to affect your diaphragm's ability to move. So obesity and pregnancy. We already talked about supine positioning and aging. Heart failure has also been known to decrease the FRC closing capacity ratio. And by the FRC closing capacity ratio, if the closing capacity is above the functional reserve capacity, remember, that's going to lead to alveolar collapse. So as the ratio decreases, you're going to have more alveolar collapse. And then abdominal surgery, because of manipulation of the abdomen and the abdominal contents, that can also decrease the FRC closing capacity ratio. So the FRC goes down. So what? Why do we care? Well, a couple of things. It decreases lung compliance as you have decreasing alveoli and more atelectasis. That means that it's going to require more pressure to achieve the same amount of volume change. So as you remember, compliance is determined by your delta volume over your delta P. So as your volume, as your alveoli collapse, this is going to affect your lung compliance. It also is going to increase your airway resistance because you don't have the radial traction that normal functioning alveoli provide to keep smaller airways open. You have increased work of breathing because now you have to work even harder to recruit those collapsed alveoli. And then because you've got those collapsed alveoli, you have decreased tidal volume, and sometimes you can have an increased respiratory rate to compensate for that. Well, how does FRC affect gas exchange? Well, FRC, or is, as you may remember, is where you have your oxygen reserve. So that's when you pre-oxygenate a patient prior to induction of anesthesia, we're trying to denitrogenate that functional residual capacity, fill it with oxygen, so we have a longer time before the patient desaturates. When you have a smaller volume in which that oxygen is, then it's going to take, then they're not going to have that nice reserve you usually have prior to induction. You're also going to have increased atelectasis, as we talked about before. And when you have atelectatic lung or alveoli that aren't effectively receiving adequate gas supply, then that's going to lead to shunting. So what is a shunt? So shunting is when there is blood flow to the alveoli, but they're not ventilated. So usually there's some element of shunt in normal lung. But it's usually less than 5%. But things that we do for under anesthesia can raise that from 16 to 20% due to the drop in the FRC. But the amount of atelectasis can go anywhere up to 30 to 50%, depending on the nature of the case. And the problem with shunt is because that area is not receiving any gas, it's not receiving any of the gas that you're delivering from the mechanical ventilator. Even if you go up to 100% oxygen, because it's not receiving any of that airflow, it's not going to be able to reverse the hypoxemia associated with shunt. When you have a shunt, the PaCO2 is usually normal or low because increased alveolar ventilation. So because they have that increased work of breathing, sometimes they, from the increased drive from associated hypoxemia can lower the PaCO2. Now, the opposite of shunt is dead space, right? And can anybody tell me what is the difference? What is dead space? Well, it's kind of the opposite of a shunt. So instead of having areas, so if this is an alveolar unit, in the shunt, right, there's blood flow coming to the alveolus, but there's no airflow. In dead space, you have airflow going to the alveolus, but you have no blood flow. So the definition is the portion of each tidal volume that doesn't participate in gas exchange. And there's no gas exchange because there's no blood flow to this unit. And remember, there's a big part of your airways that is all dead space. So if you think about it, your mouth, your larynx, your trachea, your main bronchi, even your large bronchioles, they don't have any blood flow that allows you to participate in gas exchange. So we refer to that in the conducting airways as anatomic dead space, but you can also have physiologic dead space. And that is in reference to alveoli that are ventilated, like you can see here. The alveolus is receiving airflow, but there's no blood flow. And one of the biggest classic examples for this is a pulmonary embolus. So you have a big clot that sits in the blood vessel. Despite you having adequate gas entry into the airways, there's no blood flow, so gas exchange can't occur. And when this happens, you usually have an expired CO2 that is usually less than your PA CO2 because it's not able to participate and release the CO2. So in between dead space and shunt, so in between areas of no perfusion but adequate ventilation and no ventilation and adequate perfusion, there's actually a whole spectrum. And this whole spectrum exists in all of us at any given time largely because of gravity and changes in your chest as you go down. So you guys may have heard of the west zones of the lung. So in higher up regions of the lung, in someone who is sitting like we are all are, the upper zones of the lung are very well ventilated because they don't have the effects of gravity. And so they're usually larger alveoli. But, and then as you go down further into the lung space, you have progressive increase in the relative pressures of your pulmonary capillaries, both the arterioles and the venules, and thus you have better perfusion matching to the alveoli. So you can see here what this is trying to illustrate is this one is very well ventilated, but not as well perfused because the blood vessel is a little bit smaller. As you go further in the lung, the matching between the vessel and the alveolus gets a little bit better. And you can see here, this is a diagram that's illustrating how ventilation and blood flow changes as you go down from the top of the rib cage towards the bottom. So as you can see here, the blood flow at the top is less, and as you go further down, it's increased. And the ventilation, while adequate at the top, it becomes even better towards the bottom. And this leads to areas of differential VQ matching across the lungs. So in any given patient, you can have instead of just dead space or just shunting, what happens under anesthesia is you have changes in your ventilation perfusion matching, and that can sometimes lead to hypoxemia. We will go there. So we'll also just talk briefly about what aging can do to lung mechanics. So as you get older, you have decreased compliance of the respiratory system and lung elastic recoil. Your respiratory muscle strength also decreases with age, and both of those lead to increased work of breathing. So this patient was 74 years old, so they had some of these contributions that were affecting their lung mechanics. And these changes lead to changes in their lung volume. They have increased residual volume and FRC from air trapping, decreased vital capacity, increased closing volume from loss of supporting tissues. And then what about obesity? Because we mentioned that this patient was 104 kilos, I think. Well, that also leads to decrease in the FRC because of the effects on the diaphragm. And this can cause expiratory flow limitations and airway closure. The decrease in their FRC, we talked about how that reduces oxygen compliance. The increased weight also can increase oxygen consumption, CO2 production, as well as the AA gradient. But the other lung capacities, such as the diffusing capacity, total lung capacity, usually stay within normal limits. So we talked about how the anesthesia, supine positioning, his age, his obesity, the fact that they're doing abdominal surgery can all affect the functional reserve capacity. The functional reserve capacity decline can lead to atelectasis and VQ mismatching or shunt. So what can we do about it? Is there anything we can do about it, or we just say, sorry, we'll just have to accept a saturation of 85%? And I think at this point, you guys were probably thinking, well, there's PEEP, right? Because if you apply positive end expiratory pressure, you're able to prevent those alveoli from collapsing. But really anything that increases the distending pressure of the alveolus is going to help decrease the effects of atelectasis. So applying PEEP is one way. You can also increase the tidal volume. And the way to successfully lead to better recruitment to reverse the effects of atelectasis is to do these things after doing an appropriate recruitment maneuver. So a recruitment maneuver, I don't know if you guys, there's people who do things differently, but usually what you do is you apply a positive pressure for at least 30 to 45 seconds at 30 centimeters of water so that any of those collapsed alveoli can get recruited. And then you increase the PEEP or the tidal volume so those recruited alveoli can now stay open. This allows you to have an increase in your functional residual capacity. It improves your lung compliance and reverses the effects of VQ mismatching that led to the hypoxemia. So you decide to do that. So given his hypoxemia, due to presumed atelectasis after induction, which led to VQ mismatching and shunting, you perform a recruitment maneuver and you increase the patient's PEEP to 12. His oxygen saturations, like that, they go from 85% to 92% on 100% FiO2. However, after you do your recruitment maneuver and increase the PEEP, you note that his blood pressure starts to fall from 109/69 to 88/54. So what do you think could have happened here?
This patient is probably receiving high PEEP, 200 centimeter water. So this patient will have decreased venous symptoms that will result in.
Yes, exactly. That's right. So positive pressure ventilation is going to affect the normal cardiopulmonary interactions. So in a spontaneously breathing patient, what happens with inspiration? Well, during inspiration, you have a decrease in your intrathoracic pressure, right? The decrease in intrathoracic pressure pulls more blood into the right side of the heart. It keeps the blood pooled in the pulmonary veins because it has that negative pressure. This leads to an increase in RV volume, an increase in RV output. But because of intraventricular dependence, you may have a decrease in your LV volume and a decrease in your LV output. And this leads to a decreased blood pressure on inspiration. This is normal pulsus paradoxus, right? But this is a normal phenomenon that doesn't really affect your overall cardiac output. But what happens is during positive pressure, first, those effects are reversed, right? So instead of having negative intrathoracic pressure as your diaphragm is pulled down during inspiration, now you have positive pressure that is going to impede venous return to the right side of the heart. This is going to decrease your right ventricular output, decrease your RV volume. And because when the RV expands and your intraventricular septum there's intraventricular dependence, this is going to lead to an increase in your LV volume and an increase in your LV output. And this leads to an increased blood pressure on inspiration. Again, this is normal pulsus paradoxus. But however, over the course of several breaths, you continue to have a decrease in your venous return to the right side. What actually happens is that it leads to a decrease in your overall cardiac output. And so that's something you have to be mindful of as you increase the PEEP, as you perform recruitment maneuvers, is that you can lead to a decline in your overall cardiac output and blood pressure. The only other thing that I'll mention here is that positive pressure mechanical ventilation you'll see here increases the pressure gradient for aortic blood flow out of the thorax. And so that's what leads to some afterload reduction on the left ventricle and leads to a favorable that's what leads to, and that's good for the heart, right? Because LV afterload reduction is one of our strategies for managing heart failure. But for the most part, despite you having normal pulsus paradoxus, you have a transient increase in your blood pressure with the initial breaths. Over time, the decreased venous return that's going to happen is going to lead to a decrease in your overall blood pressure. So what's another potential cause for hypotension? So this is tracings from the ventilator that show that is what another potential cause of hypotension could be. And can anybody see, can anybody guess what that might be? So I'll go over with you. So this patient is on, do you know what mode of mechanical ventilation they are? Well, the pressure is constant with each breath, whereas the flow changes. So this is a pressure control mode of ventilation because the pressure is constant and you have decelerating flow. So this is your pressure over time curve. This is your flow over time curve. These are your volumes over time. So what you'll see here is that the flow should come all the way back to zero at end expiration, right? Because that means everything, all the air in your lung, the expiratory volume has left. So what does that mean when at end expiration you don't reach zero? Well, that means even when the patient isn't finished expiring, the mechanical ventilator is going ahead and giving another breath. Well, what happens? Well, you can try it on yourself. Try taking a big deep breath and then don't exhale all the way, and then take another breath, don't exhale all the way. What you'll notice is you'll start to get progressive gas trapping. So this is something that we call intrinsic PEEP or auto PEEP, when you have incomplete emptying at end expiration. And what that can do is that can progressively increase your intrathoracic pressure and further decrease venous return and decrease cardiac output. So it's something that you have to be mindful of when you're looking at your flow tracings on the mechanical ventilator to ensure that doesn't happen. Let's say you don't have these tracings available, but how else, what's another way that you can determine that the patient has intrinsic PEEP? Well, what you can do is you can just pause the ventilator and at end expiration. And what you'll see is that there'll be a progressive increase in the pressure because there's still intrinsic PEEP there. So factors that are associated with auto PEEP include anything that requires high minute ventilation. So if you're having the patient breathe really fast to try to get rid of CO2, which can happen, for instance, in acute respiratory distress syndrome, then because they have less and less time for exhalation, that can lead to auto PEEP. The other process that can lead to it is any kind of obstructive pathology, so asthma or COPD. And again, like I mentioned, an expiratory hold can help you determine if there's any auto PEEP, because you'll start to see that there's going to be a progressive, as you hold at expiration, right at end expiration, there should be no airflow. But if there's intrinsic PEEP, you'll see a progressive rise in your pressure tracing, or if you have a bag there, you'll see that the bag will start to expand. So how can we reduce it? Well, the first thing is really to address the underlying cause. So whatever, if they have asthma and they're having bronchospasm, you can give them a bronchodilator. And then if you have them at a really high respiratory rate, then you need to consider, well, what can you do? So one strategy is to adjust the ventilator to increase the time that the patient is going to be expiring. And you can do that by either reducing the respiratory rate and or the tidal volume. The thing is, if they have high needs for oxygen, you may need to increase the inspiratory flow rate on your ventilator. That's how you address auto PEEP if the time is inadequate expiratory time. However, if it's due to some kind of flow restriction like COPD, because your work of breathing is increased, because you have to work harder at inspiration to open up those collapsed distal airways, actually what works is to match the external PEEP to what the level of their intrinsic PEEP is, and that'll reduce their work of breathing, which is kind of a more advanced concept, I think, even for all of our fellows here. So I think the big thing to keep in mind is, for the most part, for most people, you need to adjust the time that they have to expire. So let's continue with our case. So this gentleman, they found 50 centimeters of ischemic bowel, which they resected. During the case, he received 2 liters of crystalloid, and he also received 2 units of blood and 2 units of FFP because they had some abrupt and unexpected blood loss after they accidentally ligated a mental vessel. But at the end of the case, he's hemodynamically stable, but you get a arterial blood gas, which shows the following: a pH of 7.26, a PaCO2 of 76, and a PaO2 of 68. What is your plan for emergence, and do you plan to extubate? The problem with this is, even at with mechanical ventilation at an adjusted rate and appropriate PEEP, there still have a significant issue with gas exchange. So while you're controlling the lung mechanics, there's a problem with gas exchange. So do you expect the patient to succeed if you extubate him in the operating room? I mean, it's probably not going to go very well, right? So when you have a patient who still has a lingering gas exchange problem that's this significant, where their CO2 level has risen to the point that they are acidotic, and they're on 100% FiO2 on mechanical ventilation. If you extubate them to a non-rebreather, even at 100%, because now you've taken away the support for their lung mechanics, it's very unlikely that they will succeed. So you decide to leave the patient intubated and take them to the intensive care unit. So what do you think is still causing his hypoxemia? Why is he still on 100% FiO2?
Maybe it's one lung ventilation.
Pardon?
One lung ventilation.
Yep. So you could have a tube that's malpositioned. That's right. Yep. So your right main stem, and you're only providing you're only providing gas exchange to one part of the lung. So what that would be a description of shunt, right? Because you have areas of the lung that are being perfused but not ventilated. So you've created a massive shunt if you do that. Good, that's one. But there's all the other usual things that lead to hypoxemia. So underlying chronic obstructive pulmonary disease that can lead to VQ mismatch and diffusion problems. Pneumonia, pulmonary edema, ARDS, and then TRALI, which is transfusion-related acute lung injury, which can also lead to shunt. Pulmonary embolism can lead to VQ mismatch. We talked about pulmonary fibrosis being less likely given the fact that this patient doesn't have a history of it. And then also obesity, which leads to alveolar hypoventilation. Less likely because we're controlling mechanical ventilation and we've made some adjustments to the ventilator. So you get a chest X-ray to help you determine what could be the cause. So does this help narrow your differential? What do we see in the chest X-ray here? So is the endotracheal tube appropriately positioned? Do we think this patient is on one lung ventilation? Well, if you look here, here is the trachea, right? Trachea splits, here's the carina, and it splits into the right main stem and the left main stem bronchus. So when a breathing tube gets main stem, which side does it usually go? The right or the left? The right, right? So if you saw a main stem intubation, it would be sitting right here, but you can see it's here. Usually we like the breathing tube to sit about 3 to 4 centimeters above the carina. So you can see that this is a little bit high, but it's still within the trachea. The other thing I see here is I see 2 central lines. This patient has a subclavian central venous catheter, as well as a right internal jugular venous catheter. And then what do we think about the lung tissue itself? Does that look normal? I'd say it doesn't look normal. I mean, there's a lot of interstitial markings, lots of diffuse infiltrates that aren't restricted to one area of the lung, right? If it was an aspiration, we'd see it probably in the more dependent areas of the lung, predominantly in the right middle and right lower lobe. But here you can see it's really everywhere, which makes you more concerned that this is a diffuse process. So based on this history of acute abdominal surgery, large volume shifts, and the patient has worsening lung compliance, you suspect that this patient has ARDS. So I'll just give you, I realize I'm running out of time here, and I prepared so many more slides than I have time to share, but we'll just go briefly over ARDS. So acute respiratory distress syndrome. So what is it? So it is when you have difficulty with oxygenation that occurs within 1 week of a known clinical insult. So in this patient's case, he had acute sepsis due to ischemic bowel that required emergent surgery. So that's the timing portion. When you look at the chest imaging, you'll see bilateral opacities, which we saw in our chest X-ray here. There's bilateral diffuse interstitial opacities. And then the the origin of the edema or the interstitial opacities are usually not explained by some other cardiac problem like fluid overload, which is possible in this patient, but he doesn't have a history of heart disease or congestive heart failure. And he didn't receive like 8 liters of fluid during the procedure. He received 2 liters of crystalloid, 2 units of blood, 2 units of FFP. So I think given the fact that the patient received those blood products, you could still argue that maybe he had a transfusion related acute lung injury or TRALI, and I think that's fair. And then how do we classify ARDS if they have it? So it's divided into mild, moderate, and severe. And what you need in order to group a patient into these categories is an arterial blood gas. So as you may remember, this patient's PaO2 was 68. So 68 divided by 100 or 1 is PaO2 FiO2 ratio of 68, because 68 divided by 1 is 68. So if the PaO2 FiO2 ratio is less than 100, that's considered severe. So this patient would be classified as having severe ARDS. Now, if your PaO2 is higher, and your P to F, we usually call this the P to F ratio, is between 100 and 200, that's considered moderate. And if it's between 200 to 300, that's considered mild. So what leads to ARDS? Well, usually there's some kind of insult, and it can be sepsis, it can be trauma, it can be burns, pancreatitis, it can be amniotic fluid emboli, anything that releases, a bunch of cytokines or inflammatory markers that lead to increased capillary permeability in the lung, as well as surfactant dysfunction. And that leads to alveolar instability. It leads to increased opening pressure that is required and collapse of unstable units, which leads to worsening BQ mismatch and hypoxemia. And one of the most evidence-based strategies we have for dealing with ARDS is using low tidal volume ventilation. So this is the famous ARMA study back from 2000. And what they did is they were having a lot of patients who came in with ARDS and noting that they were doing poorly. So one of the things, what the study looked at was using low tidal volume ventilation of 4 to 6 mils per kilo with reduced plateau pressures versus traditional, which was anywhere up to 10 mils per kilo. And does anybody know what this study found? Which was better, low tidal volumes or traditional tidal volumes? Well, if you think about it, we now use anywhere between 6 to 8 mils per kilo in our population. So low tidal volumes was associated with decreased death. So that's why a lot of this data has been extrapolated to all kinds of populations, including patients in the operating room. And that's why we use lower tidal volume of 6 to 8 versus 10 to 12 that was used before this time.